I mean, I think politically, it's a compelling story to tell, and most agree that it's important to root out fraud and abuse, and on the Medicaid side, try to incentivize people to get back to work. I think that is a popular story to tell, and if this bill just targeted potential fraud and abuse, I think you wouldn't see all the massive coverage declines that are projected by us and the Congressional Budget Office.
Welcome to Hospitals in Focus from the Federation of American Hospitals. Here's your host, Chip Kahn.
Healthcare in America has been dealt a series of blows over the last 5 years. COVID-19, workforce shortages, inflation, and new challenges loom. With the passage of the One Big Beautiful Bill Act, policymakers have enacted sweeping changes to Medicaid and the insurance marketplaces that will leave millions uncovered and significantly reduce resources available to fund needed care. The OBBBA did not address the renewal of the marketplace enhanced premium tax credits, which expire at the end of the year. Without action, premiums will rise dramatically for millions of Americans, and as many as 5 million could lose coverage altogether. What does this mean for the millions who depend on the marketplace for health coverage? For those who stay, what happens to the affordability of their coverage? To help us break it down, I'm joined today by Frederick Blavin, Senior Fellow in the Health Policy Division at the Urban Institute. Fred brings his expertise in analyzing coverage policy and its consequences at the state and local levels. Fred, thank you so much for joining us today.
Thank you, Chip. I'm glad to be here.
Great. Well, let's just start out with you providing some background on your work at Urban Institute and the expertise that you have in this area of healthcare coverage.
Sure. I'm a health economist and the lead for the low-income coverage access and affordability practice area here at the Health Policy Division of the Urban Institute. And my research generally focuses on the evaluation of state and federal policies related to healthcare reform, medical debt, Medicaid, income and benefit policy, and health information technology. I also work on quite a few topics related to hospital, healthcare pricing, and hospital finances, as well as market power and consolidation. I've been working closely with the Urban Institute's health insurance policy simulation model, also known as HIPSIM, and the microsimulation team here at Urban on analyzing the likely effects of OBBBA and the expiration of enhanced premium tax credits on health insurance coverage, spending and provider revenue, and uncompensated care demand sought by the newly uninsured population. Just a little bit of background, the microsimulation HIPSIM is a detailed model of the U.S. healthcare system, and it's designed for quick turnaround policy analyses of proposals, including this one, as well as the Affordable Care Act and others. And overall, in the past, the results from the simulation model have been favorably compared with the actual policy outcomes and with forecasts from other respective microsimulation models.
Fred, that background obviously is going to be so helpful for our little conversation today here. Let's first, before we get into the tax credit and its importance and the implications of its potential expiration, let's talk a bit about the OBBBA that just passed. And can you, to set a context for where we are right now with coverage and healthcare funding, give us some sense of what you think the impact of the Medicaid and the Medicaid provisions, as well as those provisions in the new law that are aimed at program integrity for the exchange marketplaces where Americans buy their individual healthcare coverage.
A little bit of context, there are many provisions within the bill that are related to Medicaid and the Affordable Care Act's health insurance marketplaces that will ultimately impact health insurance coverage in the country. The Congressional Budget Office projected that the bill would increase the number of uninsured by around 12 million individuals in the country, around 8 million of which come from provisions specific to Medicaid, and an additional 4 million from provisions related to the marketplace. This increase, combined with the additional 4 million increase that's projected to occur with the expiration of the enhanced premium tax credits, represents a 50% increase in the number of uninsured in the US. So that gives a little bit of context on what the likely impact of this bill would be. Now, on the Medicaid side, I think that the key provision that is going to have an adverse effect on coverage would be the new work requirements that's specific to the ACA Medicaid expansion population. In fact, the CBO projects that nearly 5 million people would become uninsured from this provision alone. A little bit of details about the provision, beginning in no longer than December 2026, Medicaid enrollment for the expansion population would be conditional upon working or participating in a work program, community service, or enrollment in an educational program. And unlike previous state work requirement programs, this bill would require people to comply with the work requirements up to 3 months before actually enrolling within Medicaid and 1 or more months between renewals. Now, of course, there are exceptions to the work requirement component. Pregnant women and postpartum women are exempt. The medically frail and disabled are exempt. Parents, guardians, or caretakers of dependent children 13 and under, and individuals with disabilities are just some of the groups that would be exempt from these requirements. But there are requirements for states to use data matching where possible to verify if an individual meets the requirement or qualifies for an exemption. And given the timing needs a pretty fast requirement, this would involve significant challenge for states to implement based on previous work requirements that were implemented in states such as Arkansas or Georgia. Some other provisions on the Medicaid side would significantly increase the administrative burden on enrollment in Medicaid, which could adversely affect coverage. These include increases in eligibility redetermination to at least 2 times per year among the ACA Medicaid expansion population, and significantly delaying or until 2034 CMS rules that were aimed to streamline Medicaid renewal policies and transitions between Medicaid and the subsidized marketplace coverage. There are also major provisions that would freeze provider taxes and limit state-directed payments. The law would prohibit states from establishing any new provider tax or increasing rates of existing taxes, and also impose a ceiling on the amount of tax in ACA provider tax in ACA Medicaid expansion states by lowering what's known as the safe harbor limit from 6% to 3.5% incrementally from 2028 through 2034. The bill also includes cost sharing for up to $35 per services for the ACA Medicaid expansion population, lowering the retroactive eligibility period in which where Medicaid would provide coverage for qualified expenses incurred prior to the date of the application, and several restrictions on enrollment for certain immigrant populations, including limits on federal matching payments to emergency Medicaid for certain populations. And in addition, the law also includes a removal of a federal financial incentive for the remaining 10 states that have not expanded Medicaid to do so. So it lowers the federal matching rate for the expansion population if those states were to expand.
That's so helpful, Fred, to sort of lay the groundwork, the foundation for our discussion now, focusing on this enhanced premium tax credit that's made so much of a difference. I think right now we're probably at the high watermark of coverage in the United States, at least since the 2009-2010 congressional action enacting a ACA that set up the current framework that we have. What is going to be the impact on those millions? And I think we're at like 24 million covered by marketplace coverage right now. What's going to be the impact if this premium tax credit that we've had for a number of years does expire in 25, and we're back, in a sense, in 26 to the original foundations of the marketplaces and the financial incentives for coverage in the marketplaces?
A great question. Both the researchers here at Urban and the Congressional Budget Office project that around 4 million people would become uninsured if the enhanced premium tax credits were to expire. And this is on top of the coverage losses that would occur in the bill. So the marketplace components of the legislation would result in around 4 million individuals losing health insurance coverage. An additional 4 million would lose coverage with the expiration of the enhanced premium tax credit. So in total, you're looking at a decline of around 8 million individuals who previously had marketplace coverage who are becoming uninsured.
So is this a mixture of, with some of these new rules that CMS has put in place on program integrity, and then the program integrity provisions in the OBBBA, as well as the tax credits? I guess there's a mix here. What kind of people are we talking about who are going to lose coverage? What are the either the demographics or at least your assumptions about who they are and why they're losing coverage?
Right. So with the expiration of the enhanced premium tax credits, you're going to get a lot of, in general, lower income individuals who had more heavily subsidized insurance coverage. So, for example, under current law, with the enhanced premium tax credits, individuals with income between 100 and 150% of the federal poverty level pay $0 in premiums for benchmark silver plans. Those individuals will now, with the expiration of the premium tax credits, they will now face a non-zero premium dollar. So I think you'll see a lot of lower income individuals losing coverage, but you'll also see individuals, higher income individuals who also have enhanced subsidies losing coverage. These declines would be more pronounced in states that have not yet expanded Medicaid, which are predominantly in communities in the South and within rural communities. And they would be on top of the coverage losses that would occur under the OBBBA. So the coverage losses that would occur under the bill would affect both, obviously, expansion and non-expansion states, and they would increase the administrative burdens of enrolling within a Medicaid plan. So they make it very much more difficult by eliminating automatic re-enrollment for individuals with advanced premium tax credits, which right now 10.8 million people relied on that automatic enrollment in 2025. There'll be additional limits on the special enrollment periods. There'll be more several provisions related to pre-enrollment verification of eligibility requirements in order to receive the advanced premium tax credits. And there's also some additional restrictions on subsidized coverage for certain immigrant populations.
So taking both these, I'll call them the new obstacles to gaining coverage inside the exchanges, as well as the potential expiration of the tax credits, let's name names. Which states do you think will be most affected by the coverage losses?
Good question. So overall, we have done some work on projecting the spending changes associated with the bill as combined with the expiration of the enhanced premium tax credits. And we also provided estimates separately for both. So we know what the coverage and spending losses look like with the bill, as well as the losses associated with the expiration of the enhanced PTCs. Overall, at the national level, I think it's important to provide a context at the national level. We project that the 16 million combined increase in the number of uninsured will lead to a $1.06 trillion decline in healthcare spending between 2025 and 2034. And that includes from the coverage declines in the reconciliation bill and the expiration of the enhanced PTCs. Most of this decline, or 40% of it, would be attributable to hospitals. And most of the overall decline, about $800 billion over 10 years, is from the bill alone, and approximately $262 billion in the decline in healthcare spending would occur through the expiration of the enhanced premium tax credits over this 10-year period. Overall, all states are going to feel the effects of the bill and the expiration of the enhanced PTCs. And in general, declines will be more concentrated in some of these larger states. The reason for this is that the Medicaid provisions do primarily target the Medicaid expansion population and states that have expanded Medicaid. However, the marketplace provisions and the expiration of the enhanced premium tax credits are going to have larger effects on individuals in states that have not expanded Medicaid. And this is largely because the 100 to 138% of the federal poverty level population, the low income individuals in non-expansion states, are eligible for enhanced subsidies, but they're not eligible for Medicaid. So when you take away the enhanced subsidies for this group and you make it more difficult for them to enroll, you're going to see larger declines in coverage due to the marketplace provisions in non-expansion states. Overall, we're finding that the largest declines in healthcare spending are going to occur in California, Texas, New York, and Florida. So overall, more than 1/3 of the total projected decline, in spending associated just with the reconciliation bill, would occur in those 4 states. And then you also see spending declines of more than $20 billion in 9 additional states. And that includes Arizona, Georgia, Illinois, Indiana, North Carolina, Ohio, Oregon, Pennsylvania, and Washington.
Well, it sounds like it's going to be tough on a lot of people. Just so that our audience understands, it'd be helpful. Can you give us a sense for the range? You said 100. You mentioned 100% up to 138%. What are the dollar amounts of that income? I know they vary somewhat, but just sort of generally, sort of what's your benchmarks there, and so that the audience can get an understanding of what we're talking about in terms of what defines lower income.
Right. So the Medicaid expansion population, that includes individuals with incomes up to 138% of the federal poverty level. In terms of dollars for a single person, this is around somebody making $20,000 per year. So that's the population that would be eligible for Medicaid in expansion states. In non-expansion states, those between 100 and 138% of the federal poverty level are eligible for those enhanced premium tax credits and the regular premium tax credits as well. So we're talking about a very low income population that is targeted by these cuts in Medicaid and the marketplace.
So you mentioned when we talked about Medicaid and now about the exchanges, we talked about coverage, and you begin to lay out some of the dollar impacts also. We've got a lot of facilities, community health centers, hospitals, skilled nursing facilities, all kinds of facilities that will be treating these patients. What do you think the impact's going to be once the OBBBA is implemented, and then on top of that, if by 26 we don't see a renewal of the tax credits?
So what you're going to see is, and I think you'll see this very quickly with the expiration of the enhanced PTCs. I think some of the Medicaid provisions are phased in a little bit more over time, but you'll see individuals will lose their health insurance coverage. And typically when individuals lose health insurance coverage, they're less likely to utilize healthcare. Research also indicates that as individuals become uninsured, it's going to impact providers through this decline in healthcare revenue from the newly uninsured population. And those who actually do use healthcare are going to be more reliant on uncompensated care. And so that would potentially place an additional financial burden on hospitals, office-based physicians, and other healthcare providers that serve predominantly lower income populations that previously had Medicaid or subsidized marketplace coverage. And this could put an additional strain on them, as well as state and local governments who finance uncompensated care. And in the analysis that I discussed before with the spending declines, we also find that there'll be around a $300 billion increase in the amount of uncompensated care that the newly uninsured population will be seeking over this 10-year period.
So there's a big effect, and it's going to, the numbers you just provided are going to have to be met. So somehow hospitals, community health centers, other kinds of providers are going to have to figure out how to make ends meet because their mission is to provide the care. And it sounds like a lot of care will now be uncompensated that, prior to this year was covered for those individuals. Let me ask one more question before we cycle out. One of the justifications, both for the intensive changes, both regulatory and legislative, in the exchanges, the program integrity changes were put in place because of allegations of fraud and abuse of the system. And I think some policymakers and some opinion leaders even see the enhanced tax credits as something that's abusive, or there are people that are using them that shouldn't qualify because of their income level. Can you give us some sense of your view of these concerns with the marketplaces as they've been constituted over the last few years, with the tax credits in play, these higher tax credits in place?
Yeah, I mean, I think politically, it's a compelling story to tell, and most agree that it's important to root out fraud and abuse, and on the Medicaid side, try to incentivize people to get back to work. I think that is a popular story to tell. And if this bill just targeted potential fraud and abuse, I think you wouldn't see all the massive coverage declines that are projected by us and the Congressional Budget Office. I think it's clear that these provisions extend well beyond just fraud detection, and the fact that lawmakers needed to get significant savings from the cuts in the bill in order to reach some budgetary targets indicate that these coverage declines extend well beyond those who are potentially abusing the system. And in reality, I think that what it looks like to me is that the goal of the bill is to make slashes to Medicaid and the ACA marketplaces without explicitly repealing the Affordable Care Act. And I think there are a lot of examples here. If you look in the data on the Medicaid side, particularly on the Medicaid work requirement side, where a lot of the claims being made are overstated. Same on the marketplace side, with the potential for fraud and abuse within the marketplace. I think it's true that there are likely people gaming the system in terms of getting their subsidized marketplace coverage. But I wouldn't call it improper or even fraudulent, since this is just people seeking coverage in the health insurance exchanges. And by law, they're required to project their income over the upcoming year. In a lot of instances, they can anticipate that it'll be greater than that of the previous year or less than that. And I think, especially with these lower income populations, income is still volatile. You're talking about that's to people who aren't even who aren't salaried workers trying to forecast what their income is going to be like in the next year. You're going to have, it's not a perfect system. You're going to have some instances where people will be potentially underestimating their income to get a larger subsidy within the marketplace. It's also important on the data piece that I think a lot of the assumptions and the data that are out there are kind of based on faulty data and have bias due to some methodological concerns within the data, especially given the difficulty measuring income, the income volatility, and the measures that are used to kind of define that kind of CMS and some researchers have used to look at what enrollment in the 100 to 138% FBL group, for example, compared to what they look like in survey data. They're not necessarily looking at apples to apples comparisons.
Yeah, just to put an exclamation point on this, of those covered in the exchanges, let's say in 25 or 24, whichever is the year you would have data, how many fall in that 100% of poverty to 138, or in sort of that range? What proportion are we talking about who really, in most cases, probably can't afford to pay hardly anything for a premium?
Right. So in the work that we had previously done, I can't speak right now off the top of my head what I just don't know off the top of my head what share fall within that 100 to 138% FPL group. I certainly can follow up after this conversation.
Okay.
But I mean, it is, it is a relatively small group. You're talking about, I mean, it is a large group, but you're talking about a population, the subsidized population. The subsidies, the enhanced subsidies now go up to above 400% of the federal poverty level. The most generous subsidies are at that lowest income group. So you do have,
and to go beyond that, I mean, we're talking about the non-expansion states where people can't qualify for Medicaid up to 138%, where this is really, really important. It's critical path for them, right?
That's correct. And it also, would like to kind of touch on, what's being said on the Medicaid work requirements as well, in terms of, potential, not necessarily fraud within Medicaid, but this claim that's out there that people who are enrolled in the Medicaid expansion population aren't working, or they're getting coverage, but they're not actually incentivized to work. So we've done some work here at Urban Institute. I have some colleagues, Michael Cartman, Genevieve Kenny, and some others who've estimated that imposing work requirements would lead to about 6 million Medicaid expansion adults to lose health insurance coverage. And most of those people at risk of losing coverage are actually working or engaged in work-related activities or would meet the exemption criteria themselves. So, in fact, they find that around 9 in 10 expansion adults are participating in qualifying activities, whether it's work or attending school, or have other characteristics that would make them exempt from the requirements, such as being parents or caregivers for a disabled house member, and individuals who are in fair or poor health or have a functional limitation.
I mean, I think what you're getting at now is there's a cost benefit here to having policies that are designed according to their authors to root out fraud and abuse or inappropriate use of funds in whatever way. And the fact is, when you go at that, you end up affecting a lot of people who would otherwise be eligible, but the new structure makes it so difficult for them to stay signed up, right?
Yeah, I mean, they are creating policies that have adverse effects for the entire expansion population, and disenrollment. A lot of what occurs is related in behavioral economics, which shows that certain policies like on the marketplace side, like automatic or default enrollment, can have significant implications on whether or not an individual will stay enrolled in health insurance coverage. And policies like work requirements, which involve individuals potentially having to provide documentation that they're working or that they're exempt from the work requirements, that just creates an additional burden on everybody. And it'll disincentivize individuals from enrolling in Medicaid who otherwise would be enrolled, even though they're not necessarily subject to the work requirement. I think, especially now, there's going to be a lot of work on trying to automate that process, but not everyone will have automated data to determine if their work requirements. It's going to involve still a significant burden on individuals to comply with the program.
Well, hopefully over time, mitigation will be applied here, and we'll lose some people, but hopefully find ways over time to get them picked back up. And clearly, it's our objective to see the enhanced premium tax credit renewed. And it seems to me that's a minimal critical path to making sure we don't lose too much ground here in the exchanges. I mean, I think it's important to say that in terms of good, comprehensive healthcare coverage, the exchanges really provide the only marketplace for individual coverage. And if the assistance isn't sufficient there, and if the sign-up process is too difficult, then people are going to fall through the cracks, I think.
Yeah, and that's what CBO projects and what we project. I mean, when you make it so that people can't automatically, enroll every year, and they have to provide additional documentation to prove their income. That could lead delays into when they can actually receive their premium tax credits. Fewer people are going to enroll in that policy, and you're going to see this compounded with less generous subsidies. So when those enhanced premium tax credits go away, people are going to face significant increases in their out-of-pocket expenses and their premiums for coverage. And so that's how you get to around approximately 8 million people potentially losing marketplace coverage.
Well, Fred, this was just such a helpful discussion. And I hope our audience has learned something today about coverage, about these public policies that are so critical to coverage, and about changes that are taking place right in front of our eyes here real time. So with that, I just want to express my appreciation for you coming today.
No, thank you. It's great to be able to talk to you about these issues. Don't hesitate to reach out if you have any other questions, or if you want to chat again.
Great. Thanks a lot. The passage of the OBBBA and the looming expiration of the enhanced premium tax credits create a dangerous moment for health care access in this nation. Millions stand to lose coverage, not because they're ineligible, but because policies are making it harder to stay enrolled. Hospitals are already stretched thin. Patients are already struggling to access care. The last thing our healthcare system needs is another self-inflicted wound. Congress must act to prevent further damage by extending enhanced tax credits and preserving their coverage gains. The time to protect patients and strengthen care is now.
Thanks for listening to Hospitals in Focus from the Federation of American Hospitals. Learn more at FAH.org. Follow the Federation on social media at FAH Hospitals, and follow Chip at Chip Kahn. Please rate, review, and subscribe to Hospitals in Focus. Join us next time for more in-depth conversations with healthcare leaders.
Topica.